Okay, thanks, Chairman. So I'm very happy to be here to share our research work with our Harvard colleagues. Based on our research progress, I just revised my presenting title a little bit. So the current title is From Mechanistic Understandings to Precision Medicine, and the legastrozine facilitates leflunomide attenuating progressive bone erosion in RA individuals with high CRP. I just give a little bit explanation. Legastrozine is a small molecule compound from Chinese herb Chuanxiong. This is the bone erosion at the periarticular bone in rheumatoid arthritis. So it's the central feature of RA, and it's a great challenge because bone repair within bone erosion hardly occurs. Even we use the being developed by a bone edible drug by Imaging company, still it doesn't work in those mouse models for repair bone erosion. And we know leflunomide is one of the most common disease-modifying anti-rheumatic drugs since it was clearly approved by FDA. And recently, increasing clinical reports related to leflunomide in RA still increasing, especially in developing China. And there's a well-known immunomodulatory mechanism of leflunomide in rheumatoid arthritis. And we know an antigen-presenting cell and the proliferating lymphocytes and the pro-inflammatory cytokines to be combined together to play a key role in those pathophysiology in rheumatoid arthritis. And we also know leflunomide inhibiting those proliferating lymphocytes. After oral administration, the leflunomide could be metabolized to its active form, teriflunomide, and to inhibit those rapidly proliferating lymphocytes, DHODH-dependent de novo pyrimidine synthesis pathways to prevent those DNA, RNA synthesis, to inhibit those proliferating lymphocytes. So it's the classical or consensus pathway for leflunomide. But despite the demonstrated efficacy, a substantial proportion of patients don't respond to leflunomide, as mentioned by Professor Lu a month ago. So using our clinical evidence, we also found a failure in attenuating progressive bone erosion we term as PBE positive after receiving leflunomide in substantial proportion of RA patients. And you know these erosion scores still increase after treatment. So we also found a comparable inhibition of DHODH activity and the proliferation for lymphocytes from synovial fluid between PBE inactive and the PBE positive RA individuals. So it's very interesting. So we question why the progressive bone erosion still continued in substantial proportion of RA patients even after receiving leflunomide, even though there was a significant inhibition of DHODH activity and the proliferation for lymphocytes in those RA patients. And we perform bioinformatic approach to check, to predict the biomarkers for those patients. And we found those high CRP, high baseline CRP level could predict those PBE positive patients after receiving leflunomide. So this is more explanation by this biomarker CRP, the high baseline in those PBE positive patients after treating with leflunomide. And we also found the positive correlation of serum bone erosion marker TRAP5B with CRP in PBE positive RA patients during area of treatment. So it's very, very interesting. And based on our animal evidence, we also found the consistent findings. And we use a collagen-induced arthritis rat model for mimicking RA. And after induction for 21 days, we confirm CIA to develop arthritis. And we initiate those area of treatment for 28 days. And we perform two time points for those sample harvest, and the two in vivo micro-CT scan for bone erosion, bone resorption, bone structure, and the 3 time points for serum CRP. And we found the failure, consistent findings with clinical trials, failures in attenuating progressive bone erosion, PBE positive, in substantial proportion of CIA rats with high baseline CRP, we term as CRP-BH, after receiving leflunomide. And consistent, we also found a comparable inhibition of DHODH activity and the proliferation for lymphocytes from synovial fluid between PBE negative and PBE positive cell rats. So consider with those findings in clinical data. And we found no significant inhibition of serum CRP level and osteoclastic activity in those cell rats with CRP-BH after receiving LEF. So we have some point 1 for summary. Progressive bone erosion, termed as PBE positive, could be produced by high baseline CRP in the substantial proportion of both IE patients and those cell rats after receiving leflunomide. So this is point 1. So we question the gap. What's the potential connection between the high baseline CRP level and the poor response, progressive bone erosion to leflunomide in the substantial proportion of RA individuals? And we know CRP is produced in liver to release the plasma CRP and to meet osteoarthritis bone resorption during RA progress. And we use the CRP, anti-CRP monoclonal antibody to local injection for intra-articular injection to those CI rats, and we found the attenuated bone erosion in CI rats. So it is to establish the role of CRP in bone erosion during eye progress. So we establish the correlation between CRP and bone erosion. Another one is leflunomide in one paper published by another colleagues. Leflunomide rather than its metabolite, teriflunomide, as an agonist of the AHR. So it's the relationship between leflunomide and AHR. And another paper is show inhibition of CRP production by AHR activation in hepatocytes. So this paper to indicate the relationship between AHR and the CRP. So leflunomide and AHR and the CRP, the potential relationship implying the mechanism. So we question, besides the well-known immunomodulatory action of leflunomide via its metabolite, A77, means teriflunomide, whether leflunomide itself could effectively activate AHR and then inhibit CRP production in RA individuals with CRP-BL rather than in RA individuals with CRP-BH, and then leading to the distinct therapeutic effects of leflunomide in those two RA subgroups of individuals. So it's our hypothesis postulation. Now we check the structure of AHR. So there are two structure domains, pass 1 and pass B, for binding of ARNT to AHR for activation by the agonist. So we see these pictures show the complex agonist AHR and ARNT, and the complex formation translocated to the nucleus to transfer the type genes. So it's the schematism. So we use these clues. Then we perform homology modeling of pass and pass B. This is the homology modeling. And we check the potential interaction between the leflunomide and AHR. And we produce 3 residues in those modes. And then we use the co-IP and link to HPLC mass or DATS, drug affinity responsive target stability, to check the interaction, potential interaction of the residues involved in the AHR-leflunomide interaction. And this box just showed the leflunomide could bind to the AHR. And this picture also showed their interaction because of the two aspects. This box checked that the leflunomide. This picture showed to check the proteins. We manipulate the protein, mutate those residues. So to confirm the key residues involved in the interaction. And this CRP data also show the enhanced binding of ARNT with AHR and the inhibition of CRP here, production by leflunomide rather than its metabolites, 877, in normal hepatocytes. So this is in normal hepatocyte. And we found no enhanced binding of ARNT with AHR and no inhibition of CRP production by either leflunomide or its metabolites in interleukin-6 treated hepatocytes. Here we use interleukin-6 to mimic inflammation environment in hepatocytes. And then we checked the in vivo data, and we found in addition to those, the metabolite pathway, teriflunomide in cell rats with CRP-BL, and we also found leflunomide could exert inhibition of CRP production independent of its metabolite pathway to attenuate bone erosion. And we also found no obvious inhibition of CRP production by either leflunomide or its metabolites. So we postulate concurrent actions of leflunomide on DHODH-based immunomodulation pathway and AHR-based regulation of CRP production in CRP baseline low-level RA individuals rather than in this box, in CRP high baseline. So in the two different populations, and in baseline low-level RA individuals, the two pathways work. But in this high baseline level of CRP, and this pathway maybe work, but cannot inhibit osteoclastic activity. And this pathway, AHR-based activity, doesn't work. So we have point 2 summary. Leflunomide plays concurrent actions, including the consensus DHODH-based immunomodulation pathway and our newly discovered HR-mediated CRP regulatory mechanism in CRP low baseline RA individuals. Then we question why high CRP level limited the agonistic effect of leflunomide on AHR activation and inhibition of CRP production in those CRP high baseline RA individuals. And we checked the literatures and in the database, and we found one paper showed ARNT mediated crosstalk between HIF1 alpha and AHR. So it means ARNT can bind to HIF1, can also bind to AHR. So we use these clues and to check HIF1 expression and activation in those inflammatory livers. And we found positive correlation between hepatocyte HIF1, highly expressed and highly activated, and with some CRP in CRP high baseline cell rats. And then we found the CRP data, the positive co-regulation of HIF1 by CRP. So we want to establish the role of CRP in regulating HIF1. Then we manipulate HIF1, use silencing, siRNA silencing, or overexpression of sectors to check the change of HIF1. And we found use silencing CRP and found a low expression of HIF1, and we overexpress CRP. We found highly activated or high expression of HIF1. And we also found more binding AHR with ARNT in those silencing contexts. And we found no less binding of AHR with ARNT in those CRP overexpression environment. So this data show the positive regulation of HIF1 by CRP and the competitive binding of ARNT between AHR and HIF1 alpha in hepatocytes in inflammation rates. So this is the schematic diagram to show the dysfunctional mechanism of leflunomide on inhibiting CRP production in RA individuals with CRP high baseline. So this box shows the low baseline, and the leflunomide could activate HR with participation of ARNT to inhibit CRP. So for those population, it's okay, it does work. But in those patients, in those rats, high baseline CRP level, we found leflunomide cannot activate HR because maybe CRP highly expressed and highly activate HIF1. And HIF1 can competitively bind ARNT from the complex AHR, ARNT, and leflunomide, so leading to the ineffective activation by leflunomide because no more binding ARNT with HR and more binding ARNT with HIF1. So it's the such a cycle. So our hypothesis is HIF1 alpha could be a therapeutic target for improving HR activation by leflunomide to facilitate inhibiting CRP in hepatocytes inflammation environment. So we manipulate HIF1 by silencing, so siRNA silencing, and then we found targeting HIF1 could improve AHR activation by leflunomide, and then to facilitate inhibiting CRP in interleukin-6 treated hepatocytes, but single HIF1 silencing cannot inhibit CRP. So the HIF1 targeting silencing could facilitate leflunomide and cannot inhibit CRP. So it's desirable to screen next small molecule regulator of HIF1 to improve HR activation required by leflunomide to facilitate inhibiting CRP in those inflammatory hepatocytes. So it's the summary point. High hepatocyte CRP induce aberrant expression of HIF1 alpha, and which competitively binds with ARNT, leading to ineffective AHR activation and the CRP inhibition by leflunomide in those CRP-BHI individuals. So we try to screen molecule regulator or molecule compound to inhibit HIF1. So we established HKBU Translational Medicine Drug Discovery Platform 1.0 version. There are a series of modules in this platform and not limited to this. So using the text mining modular and the data integration modular and the system biology modular in HKBU-TMDD 1.0 version, and we constant regulation network of HIF1 production. So the blue and the red circle just to indicate the direct and indirect transcription associated with HIF1 production. So we believe we hope the candidate small molecule drug should target the components in the regulation network of HIF1 production. And this is the adverse reaction network of leflunomide constructed by our adverse reaction modular in this platform. So we hope the adverse reaction network of the candidate small molecule drug should have no more overlapping with that of leflunomide. And this is the similarity of the candidate small molecule drug with leflunomide by our drug similarity modular in this platform. So we hope the chemical structure of the candidate small molecule drug should have no more similarity with that of leflunomide. Otherwise, the candidate small molecule drug could have potential competitive binding with the target of leflunomide. So combined together, we define the scanning strategy. One is to mark the small molecules, and the second is inhibition of HIF1 production, and the less overlapping adverse reaction, and less chemical similarities. So we combine the FDA-approved drug database and the chemical small molecule database and natural product database, and to screen, to virtual screening, to hope to seek the potential drug molecules. And by 3D plots of the inhibition score or adverse reaction score or similar score, and the legastrozine was predicted as the potential drug molecules. So it's the positive working principle for legastrozine. Legastrozine could suppress HIF1 to facilitate leflunomide activating here AHR to inhibit CRP production in hepatocytes for our individuals with CRP high baseline. So this is the working principle for hypothesis. And here, legastrozine is derived from the Chuanxiong Chinese herb. So in Chinese herb, Chinese practice, we use transient to promote circulation in heart disease and cardiac diseases. And this is the structure of legastrozine, and it's a legastrozine injection formula. So we have the summary point. Legastrozine is screened as the candidate with clinical approval. High inhibiting potential for HIF-1 and few or less protein overlapping adverse events and stress similarity with leflunomide. Then we validate the legastrozine in vitro. So the data showed here, legastrozine could suppress HIF-1 alpha, so less expression, and to facilitate leflunomide activity AHR, so more binding ARNT with AHR, and to inhibit the CRP in interleukin-6 treated hepatocytes. But the single legastrozine cannot inhibit CRP, so it's the facilitator and not CRP suppressor. And we could culture the condition medium from the hepatocyte treated with interleukin-6 to mimic inflammation environment with the osteoclast precursors. And this is the trap staining, and we quantitative the resorption pits also found legastrozine could facilitate leflunomide inhibiting osteoclast differentiation and osteoclast activity in vitro. Then we perform experimental validation in vivo. We still use SD rats and for 21 days for developing arthritis and to initiate LEF in combination with legastrozine for treatment. And we found that legastrozine could facilitate leflunomide inhibiting CRP production to attenuate bone erosion, here, bone erosion in cell rats with CRP high baseline level. And this in vivo data also show that legastrozine could facilitate leflunomide decreasing osteoclast activity. So this box is from the bone histomorphometry to quantify the osteoclast activity. And this is the bone resorption, and I use the bone slice to check the trap staining. And more importantly, we hope to check the safety when the combination. So far, we found no obvious hepatic and renal toxicity of leflunomide in combination with legastrozine in cell rats with CRPH. So we have summary point. Legastrozine could suppress HIF-1 to facilitate leflunomide activating AHR to inhibit CRP production and attenuate bone erosion in cell rats with CRPH. Then, very important, to check the hypothesis in clinical trials. So we perform clinical validation. This is the flow chart of clinical assessment. And this clinical registration in China platform. And this participate enrollment, include criteria, exclude criteria based on the guideline from the SFDA. And this is randomization blinding. And this interventions, the dosage and the duration for 1 year. The endpoint assessed at baseline and 6 months and 12 months. The primary endpoint is bone score, based on the radiograph score and the bone resorption marker. And the second endpoint is serum CRP level measured by ELISA analysis. So the radiograph data just show the legastrozine could facilitate leflunomide inhibiting here CRP production, bone resorption marker, and attenuating bone erosion in RA patients with CRP high baseline level. And very important, we found no obvious hepatic and renal toxicity of leflunomide in combination with LIG in RA patients with CRPH. So we have the last summary point. The study not only advanced the mechanism understandings of action of leflunomide, but also present a precision medicine-based therapy strategy. Legastrozine could facilitate the leflunomide inhibiting CRP production and attenuate bone erosion in eye patients with CRP high baseline level. So I thanks to the collaborator centers, the TMBJ in Hong Kong BU and the China Academy of Chinese Medicine Science in Beijing and the first affiliate hospital of Anhui University of Chinese Medicine. And we also appreciate the supervision of the PI, Professor Aiping Lu, and our talent guys, Dr. Liang Chao, responsible for experimental design and clinical sample analysis, and our talent guy, Dr. Dao Gangguan. He is responsible for bioinformatics analysis to mimic those in vitro screening, and also the Dr. Boris Guo, responsible for in vivo study, and Dr. Liu Jing for in vitro study. Thank you.